Hi, I'm Sandhya from Family Third Year. Today my topic is about obstructive sleep apnea. We all know that normally the air flows smoothly from the nose to the mouth and the lungs. When this normal flow stops, it is called as cessation of breathing or apnea. When this cessation of breathing occurs due to the obstruction of the airways during sleep, this is termed as OSA. So let me just introduce about OSA. OSA is also referred to as obstructive sleep apnea hypopnea. It is a condition involved in the disrupted breathing or decreased airflow during sleep due to obstruction. This condition is the most common sleep disorder breathing condition, which will affect approximately 2 to 9% of the general population, where males are affected more rather than the females. It will affect 13% of the men and 6% of the women. Where increasing in the prevalence over time, it is estimated at least 75% of the severe OSA remain undiagnosed or misdiagnosed. Before we talk about OSA, it is important to look at two types of sleep apnea. CSA, it is called as central sleep apnea. With CSA, this is a condition where there are episodes of apnea where there is decreased airflow, but the decreased airflow is due to no respiratory effect that lasts for greater than 10 seconds. Pathophysiology. The reason that CSA occurs is due to an issue with brain signaling to trigger respiration. It's involuntary control of respiration. It may be due to underlying heart diseases or brainstem disorder or idiopathic. Obstructive sleep apnea. The topic of this video is about obstructive sleep apnea. There is decrease in the airflow for greater than 10 seconds but occurs in the presence of breathing effort. The pathophysiology behind why OSA occurs is recurrent airway collapse, more specifically due to the relaxation or collapse of muscles due to low muscle tone. Let's start with the clinical features of OSA. Apnea. It is a cessation of breathing or airflow. The episodes of apnea can occur many times during the night, and these episodes of apnea can be witnessed to bring attention to it. Snoring. This snoring is going to be very loud, chronic, and bothersome to others. Not all patients who snore will have OSA. It is very important to look at whether snoring is disrupted or stopped during apnea, followed by the snort. Morning headache. Headache in the morning is due to snoring or decreased issues of breathing. They can have daytime sleepiness or concentration problem and may also have decreased oxygen saturation levels. Repeated nighttime arousals and awakenings because of their episodes of apnea. They can have insomnia, which is difficulty in sleeping. Nocturia, increased urination during nighttime, gasping or choking sound as a characteristic feature that increases the likelihood of the patient towards OSA. They can also have dry or sore throat. The main key components of OSA are snoring, sleepiness, decreased O2 saturation, and other observed apnea episodes. Few risk factors for developing OSA. If there is obesity, which leads to more tissue around neck, lead to obstruction. There is a difference in prevalence between male and female patients. Being male gender is also a risk factor. Older age and having family history, and then particularly the anatomical features. Those include large tonsils can reduce the diameter of the airway. A condition called retinognathia, where the jaw is pushed backward toward the posterior lead to reducing the diameter of airway. Sleeping supine, that's sleeping on the back, and drinking of excess of alcohol and smoking. Pathophysiology. What happens during sleep apnea? The pharynx function for both breathing and swallowing. During apnea, the soft wall collapse obstructing the airflow. It can collapse in the anterior posterior dimension. It can also collapse from the side to side. It means the lateral wall collapse. Many patients over 50% will have multiple levels of collapse in different part of the throat. This doesn't occur during the daytime due to a couple of factors. One is usually the upright position and the second is the muscle tone is greater in the daytime. Active muscle tone prevents these muscular walls from collapsing. Genioglossus muscle tone decreases once the patient falls asleep. Pathophysiology behind what happens in OSA to cause some of those health conditions. OSA causes arousals because OSA leads to episodes of apnea and hypopnea. OSA leads to decreased airflow and also leads to decreased intrathoracic pressure. These three leads to downstream consequences. With arousals, a patient becomes awakened by their snoring or their episodes of apnea. They are going to have increased catecholamine levels and those increased catecholamines which are epinephrine and norepinephrine, which leads to increased blood pressure and heart rate. Coming regarding to O2 desaturation in the hypercapnia lead to decreased myocardial O2 delivery and also lead to oxidative stress and inflammation. Decreased intrathoracic pressure may lead to increased left ventricular wall tension, increased cardiac O2 demand. With all these, OSA can risk to following condition: hypertension, cardiovascular disease, LV hypertrophy, heart failure, arrhythmias, and stroke. The risk of medical conditions like hypertension, gastroesophageal reflux, cardiac arrhythmias, heart failure, pulmonary hypertension, stroke, depression and anxiety, sexual dysfunction, and metabolic syndrome. How to diagnose OSA? Clinical examination where we note the signs and symptoms. Blood tests oftentimes are not going to be required, but they can be important when there is an association with the hypothyroidism. Checking TSH levels like T3 and T4. Sleep study, also known as polysomnography, it is a definitive technique. It records patients' respiratory rate, brain activity, eye movements, muscle and heart rhythm during sleep. Polysomnography shows the readout of airflow and the respiratory effort measured. In OSA, as we mentioned before, there is cessation in airflow for at least 10 seconds but in the presence of persistent respiratory effort. In central sleep apnea, where it is cessation of airflow for at least 10 seconds but without presence of respiratory effort. How to treat OSA? Lifestyle modification, weight loss. It is an important risk factor for getting OSA. Alcohol avoidance is also important, especially 4 to 6 hours prior to the bedtime. Positional therapy, which just means sleeping on the side instead sleeping supine or sleeping lying flat, is going to reduce episodes of apnea. Oral appliances, the use of specialized mouthpiece can also be useful in the reposition of the jaw forward, which helps open up the airway so that breaths can flow more freely. Use of non-invasive ventilation. CPAP is the most common type, although BiPAP may be used in some cases. Moving on to the pharmacologic therapy. Modafinil, which will reduces the daytime sleepiness. Protriptyline increases the respiratory drive and improve upper airway muscle tone. Metroxyprogesterone acetate and acetazolamide are used for sleep apnea associated with chronic alveolar hypoventilation. The surgical management includes simple tonsillectomy. If the patient is having hypertrophic tonsils, we can simply remove the tonsils and which the airflow increases and can also reduces the chances of collapsibility of the airways. Uvulopalatopharyngoplasty. The surgery consists of tissue rearrangement at the uvula, soft palate, throat walls in order to increase their size and decreases the tissue collapse. Maxillomandibular surgery, in which the maxilla or the mandible is surgically advanced to increase the pharyngeal lumen. So this is all about the obstructive sleep apnea. Thank you.